So good afternoon, everyone. My name is Jennifer Brigg-Murtazashvili. I'm the Director of the Center of Governance and Markets here at the University of Pittsburgh, and it is a real honor to have with us Jevay Grooms, who's an assistant professor at the Department of Economics at Howard University, and she's here to share her research on the effects of COVID on health workers and mental health and a lot of really interesting things. And it's really timely research. And we're just so grateful that you could join us today. So the floor is yours.
Thank you. I'm so happy to be here. Thank you guys for having me. Okay, I'm going to start sharing my screen. So before I get started, I want to do a little background of how this work even started. Two of the co-authors are my good friends, Alberto Ortega, Joaquin Rubalcaba, and we worked in a writing group together. And we just happened to be talking right before COVID hit, and we started to say, and we really need to track what's going on with COVID because we really think it's going to have a disparate effect across races. He reached out to some people he knew, Gabe Sanchez, some political scientists, and we were able to kind of jump on a survey that they had started right before COVID was announced as a national emergency. So this was like serendipitous. We just got really lucky with the timing and being able to think this through and be part of the team that came up with a survey. And that's how this project started. So I'm going to talk about a paper we just finished called Racial and Ethnic Disparities, Essential Workers, Mental Health, and the Coronavirus Pandemic. It is with myself, Alberto Ortega, who's at Indiana University, Joaquin Rubalcaba, who's at University of North Carolina, Chapel Hill in the Public Policy Department, and Ed Vargas, who's at Arizona State in Transborder Studies, I believe is his program. So I'll do a shameless plug for the American Economic Association summer program, which Howard is going to be hosting. And then I'll get into the background, the data, methods, results, our conclusion. And from this survey, we have a couple of other papers, one which was recently conditionally accepted as an educational researcher. And so there's a lot of work that we're doing as it relates to mental health using the survey data. Please feel free to interrupt, ask questions, clarifying questions, suggestions. I welcome all the feedback. So the American Economics Association Summer Training Program has been around for decades, and Howard is the newest host. Previously, it was at Michigan State, and I'm really lucky to be part of the board that is in charge of instituting this program, and it'll be at Howard for the next 5 years. It is an intensive residential program geared to getting students prepared for grad school. You don't have to have an undergraduate in econ, but there are kind of requirements that are expected, right? Having taken calculus. And it's a great opportunity to get graduate level coursework, but also get exposure to what a PhD in economics may look like so that you can decide if that's something you want to partake in. Okay, so Bob is fuzzy.
Okay, can everybody hear me now? Yes. Okay. Okay, so I will turn off my video while presenting, and hopefully that helps. So yeah, the AEA Summer Program is a really great opportunity. The idea is to broaden participation and increase diversity in economics. It's a 2-month program. Undergrads and graduate students, master's level, can apply, and you get fully funded, you get a stipend, you get to see great seminars, you get to do research at think tanks, and so it's a really great opportunity. Please share with your students, your networks. I put the link to the application there. It's open until January 31st. We have listening sessions if anyone has any questions, and also feel free to send me an email if this is something you think you have students that are interested in and would like more information on it. Okay, now getting to the paper. I love to put pictures of my co-authors up so people can see what they actually look like. But these are my co-authors on this paper, and Alberto and Joaquim and I actually have 2 other papers on coronavirus pandemic as well. So as of today, COVID-19 has claimed over 235,000 lives. It accounts for 9.7 million confirmed cases. January 21st marked the first reported case, and February 29th marked the first reported death from the coronavirus. On March 13th, our president declared it a national emergency. And by the end of March, 30 states had stay-at-home orders. So the pandemic is disproportionately impacting mortality within communities of color. And our concern is twofold. One, what role does social and economic conditions that increase exposure to the virus play in constructing racial and ethnic disparities in COVID-19 cases and mortality? And then 2, what we'll focus on is, as the US charts a path forward, how will it incorporate policies that ensure racial and ethnic equality as part of the recovery without understanding how COVID-19 has impacted Black and Hispanic communities beyond viral exposure and mortality, right? So this beyond viral exposure and mortality is the focus of this paper. So just early on, getting into what are we interested in? So given racial and ethnic disparities in COVID-19 cases, mortality, and exposure, we use a nationally representative survey to assess how reported mental health distress differ by race and ethnicity and current employment status. So I'm gonna get into a little bit of the background and then directly into the data and methods section. So I'm gonna talk through this screen. So this is from April 15th. The data we're using is from wave 2. So I wanted to focus on what was happening at the time that we're the analysis of our survey, when we're getting our survey in. And so your left screen should show cases. At the very bottom, you should be able to see it says ratio of cases to the total population. And on the right screen, the map should be deaths. And so what this is showing you is whether there was an overrepresentation or underrepresentation of deaths by race. So this is individuals that are white. So for instance, in Georgia had 16% cases were identified as white, 36% of deaths were identified as white, and they're 52% of the population in Georgia. So the number of cases and deaths were underrepresented in Georgia. And then if we go down to Wisconsin, it's individuals that were white, and this is data collected from the CDC. So data wasn't available for all states. So for those states that the CDC had racial data on cases and deaths. So in Wisconsin, individuals that were white that had contracted COVID represented 51% of cases. It represented 57% of deaths, and they are 81% of the population. So again, underrepresented, right? Now, if we go on to look at those individuals that were identified as Hispanic, Georgia is 4% of cases, 3% of deaths, and 10% of the population. So for individuals that were Hispanic in Georgia, they were underrepresented in cases and deaths. Now, when we look at Wisconsin, which is one of the oranger ones on the left, they represent individuals that were Hispanic represented 12% of the cases in Wisconsin, 5% of the deaths, and 7% of the population. Now moving on to individuals that were identified as Black by the CDC. In Georgia, they are 24% of the cases, 51% of the deaths, and 31% of the population. So while they're underrepresented for cases, they are overrepresented for deaths. And then I also include Illinois and then Wisconsin. So individuals that were Black represent about a quarter of all cases in Wisconsin, 39% of deaths, and only 6% of the population in Wisconsin, right? Only 6% of the population in Wisconsin are Black, but yet 39% of COVID deaths in Wisconsin as of April 15th were Black. And I put it all together so we can just kind of see the gradient right? The top panel are individuals that had cases and deaths who are white, then is Hispanic, and then is Black. And so in this paper, we talk about worker typology. And so I just wanted to reaffirm that what we're seeing in mortality, mortality across the state is roughly, we're also seeing something similar among this working age group, right? So I looked at using CDC data, we looked from 18 to 49, and the brown represents those individuals who are white. So they are roughly 23.3% of hospitalizations by the data leading up to April 25th. Individuals that are Black across the United States represented 38.4% of hospitalizations for this age group, 18 to 49. So I'm focusing on 18 to 49 because we're looking at this working age, because we're gonna focus on worker typology. And Black individuals that are Black in the United States is about 13%. So that's almost 3 times their national population, the percentage nationally. And then individuals that were Hispanic account for about 25.2% of hospitalizations by the end of April, and they're roughly about 17% of the US population. And all the way on the right, the overall, that is across all age groups. Okay, so now getting into the data. So a lot of economists like causal work. This is mostly descriptive in nature. We could not get at anything causal given the small sample size. Well, 3,000 is not small, but given that it's a nationally representative data, it's fairly small. But it's unique because we were able to collect data right when COVID started. We were able to collect data pretty early on, even before the pulse survey started. So the data set we're using is the National Panel Study of COVID-19. It is a private survey that a group of researchers across at UCLA, University of New Mexico, Arizona State, and UNC Chapel Hill have all collaborated on. It's administered by Matt Barreto, Tyler Renee, and Gabriel Sanchez. And so we were really lucky to be part of this. We were able to get in at wave 2. So wave 1 happened, was fielded early March. And wave 1, most of the individuals on the survey, on the study are political scientists. And a lot of the questions were around wearing masks and beliefs, different racial beliefs and Trump supporters, whether you're a Republican or Democrat, a Trump supporter or not a Trump supporter. So it was really getting at kind of these political characteristics as it relates to COVID and behavior in mitigating risk during COVID. And so during wave 2, while we have access to data for wave 1, wave 2 is when Alberto and Joaquin and I were able to come in and introduce economic questions and also mental health and education questions. And so wave 2 was fielded on April 10th. It was fielded for about a week and a half. We got a little bit more than 3,000 observations in wave 2. And then we also have wave 3 that we are using for other research. But in this paper, we focus on wave 2 as this is around the time that states have all instituted, not all states, most states have started to institute the stay-at-home order and the essential worker, the identification of an essential worker began. So in this analysis, we focus on wave 2. In wave 2, we have a little bit over 3,000 observations. It's nice because we have about 2,000 observations from wave 1. So we have part of our survey is a panel, and then we have a fresh cross-section of a little bit over 1,000. This survey is National Household Survey. We collected zip code data. And to give you a breakdown of this data, it's at 70% white, a little bit less than 10% Hispanic, and a little bit less than 10% Hispanic and about 12.2% Black. The goal was to overrepresent minorities. And as I'm sure a lot of people are familiar with, it's really hard to get a national representation of minorities in surveys. So we didn't quite hit our goal of overrepresenting, but we got close to national representation.
Can I interrupt briefly? I just have a question about recruitment of respondents, how you were able to recruit, and just maybe something about the response rates.
Okay, so we used, I actually highlighted this. Sorry, I'm going to leave the screen sharing. I should have.
And I ask because this is a sore point for us. It's very hard.
So I'm going to, let me tell you exactly how. So we used, the survey was conducted online by market research firm Lucid Holdings. Initial respondents, so we used a nationally representative sample collected from the Pragmatic Sampling Marketplace. So I believe our actual response rate is high, but it's because we went through Lucid Holdings. I am not as familiar with the qualitative aspect of it. I know we have a response rate, I think, in the paper. I just don't know it off the top of my head.
So it's from an existing panel that they have?
Yes, it's from an existing panel, yes.
All right.
Yes.
Perfect.
I know some people that are trying to get at mental health have used the Pulse survey, but the Pulse survey response rate is really low.
Right, and this is an internet survey, internet-based?
Yes, internet, yes. Yep, not a phone call, it's an internet survey.
Okay.
It is. And so wave 2 is what we're focusing on. That's when we are able to introduce these economic and mental health questions. We were able to, let's see if it's in the next slide. So we actually introduced a lot of different questions. We wrote a piece for Alberto and Joaquin, myself wrote a piece for the Brookings, a blog post, and we focused more on the unemployment insurance benefits and income and financial instability. But our employment breakdown, most of the people were not in the labor force. I will present some healthcare worker results, but I also present our healthcare worker results with a caveat that we do not have a lot of observations. And when we start breaking healthcare workers down by race, it becomes even more difficult to generalize those results. But we also have information on physical health, exercising, eating habits. We asked questions about distance learning if they have children in their household. We have information about the size and composition of the households, the ages, if it's a 2-parent household, single-parent household, if there are grandparents that live in the household. But the focus of this paper is employment and this mental health question we asked. So we want to get at mental health distress. And so we used 3 of the inventories from the PHQ-9, which looks at depression. And we used 2 inventories from the GAD-7, which looks at anxiety. And the survey is in here to tell you exactly what inventories we used. While it was been nice to use all of them, we just did not have the means to add that many more questions to the survey. And so the mental health questions on the survey asked, in the past 2 weeks, how often have you been bothered by the following problems? And so for anxiety, it's 1, feeling nervous, anxious, or on edge. Or the second question was not being able to stop or control worrying. And for the depression, our quasi PHQ-9 inventories, we said little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble sleeping at night. And each of the mental health inventories were surveyed using a 4-point scale. Not at all, several days, more than half the days, nearly every day. And so there are some limitations to this, right? So our analysis is descriptive. It is not causal. We do not infer that there's causal relationship, but it's descriptive. But we think descriptive data on understanding the different stressors and the variation in mental health distress across vulnerable groups is extremely important to understand as we think about whether the ACA may get rolled back, or when we think about access to insurance and access to adequate healthcare. So we recognize that there could be selection bias in terms of employee type represented. So we weight the data, and we have a part in our paper that defines how we weight the data. One of the biggest caveats is we have no baseline analysis. We do not know how these individuals were, their mental health prior to COVID. And so we aim to gauge this by looking at Burfus. Right, so we'll present some of the information from Burfus, right, the behavioral factor, behavioral risk, surveillance. I know I'm messing it up. I always mess up Burfus. Okay, so this is kind of gauging pre-COVID and then COVID. So what this map is, or what this graph is we, the blue is our COVID-19 survey, and the red is Burfus from 2018. And so we can see across the board, whether we're looking at depression or anxiety, right, our quasi PHQ-9 or a quasi GAD-7, we can see that everyone is reporting elevated levels of depression and anxiety, right, across the board, whether you're white, Hispanic, or Black. And we use these 3 race and ethnicity categories because we simply did not have enough data for Indigenous people or individuals identified as Asian or Pacific Islanders. So revisiting our research questioning, starting to get into the methods. So how does reported mental health distress differ by race and ethnicity and current employment status? So to preview our results, overall, Black and Hispanic workers display elevated levels of mental distress relative to white workers. Results suggest elevated mental health distress for all Black workers, particularly essential non-healthcare, and for Hispanic essential non-healthcare workers. So for Black workers across many of the inventories, not all, but majority of the inventories, it really didn't matter whether they were an essential worker, a non-essential worker, or an essential healthcare worker. They reported elevated levels of mental health distress. And for individuals that were identified as Hispanic, we typically or most of our inventories for essential non-healthcare workers where we saw elevated levels of mental health distress. Okay, let me keep an eye on the time. Okay, so I'm getting to the results in a second. So I think I'm going to skip the methods, but I wanted to show you that we use 2 models. So to assess mental health distress across race, ethnicity, and worker typology, we employ 2 models. The first is the probability of experiencing mental health distress across individual inventories. So one of those, there's 5 questions, right? So each of those 5 questions. And then the second model, we use OLS to examine the severity of mental health distress, right? Ordinary least squares to examine the severity of mental health distress across a quasi GAD-7 and a quasi PHQ-9 score. And so these scores sum up your response, and that creates a score in a similar way to what Burfus does and other mental health assessments do with GAD-7 and PHQ-9. So our logistic regression for model 1, our dependent variable is a dichotomous one, which it's 1, you say you have any level of worry in the past 2 weeks, and 0, you have none. We did test this to look at whether you say you have some worry, right? It's robust to all those different levels. So we left it as 1 if you report any worry, 0 if you report no worry. And our E is our employment indicator. And then this interaction term, our E and our R, is our employment indicator interacted with the race and ethnicity. And our estimates are marginal effects, given that this is a categorical variable. And then our second model, we transform our severity scores to a Z-score. And we use this to interpret the intergroup differences. And so we use an OLS model where the ZI represents the Z-score. And again, the variable of interest is our E sub I interacted with our R sub I, which is our employment variable, interacted with our race and ethnicity variable. And our estimates are marginal effects since this is a linear model. Okay, I'm gonna come back to this. So in words, what do we find? So I split these up into different groups. So essential non-healthcare was really the focus of this paper. This is really what drove us to study this, is we said There are so many frontline workers that are disproportionately Black and brown. They have to be incurring a higher level of mental health distress. One, that they are determined to be an essential worker, so they don't have the option to not work, right? They're not working from home. They don't have that luxury. And they also tend to be lower income, right? Or receive lower wages. So what we find is essential non-healthcare workers who said they were Black for the B, we find increase in significant across all the inventories. And the increase is from 27 to 52 percentage points. And those individuals who identified as Hispanic, we also find increased and significant for all inventories from the range of 33 to 62 percentage points. And so those are identified in the green box. So these are the inventories for the GAD-7, and depression, pleasure, and sleep are the inventories for the PHQ-9. So as a first stage, we looked at each individual inventory and we estimated the probability of mental health distress. And so we see, right, highly significant for the GAD-7 inventories, and we see slightly significant for depression and pleasure and highly significant for sleep. And for Hispanic, we see highly significant for all 5 of these inventories: anxiety, worry, depression, pleasure, and sleep. We also see for essential healthcare workers, we see that individuals that are Black have an increase in significant for 4 or 5 inventories from 30 to 43 percentage points. For Hispanic, we did not find it significant. And something we thought was interesting is for Black non-essential, so still employed, but working at home, we find that for the anxiety and worry, they report significantly higher mental health distress, and also for sleep. And I don't know if I have time to get into this, but this is interesting, but it's not too surprising. There's a whole body of literature that talks about, there's a saying, I think it's last to be hired, first to be fired. And that's for individuals that identify as Black in the workforce, right? There's a lot of labor research on it. And so while they're not have higher exposure to COVID because they are at home, they still do have elevated risk of possible unemployment. And so what we did, so we had our first stage, and now our second stage is we then created these Z-scores to sum up to create a PHQ score and a GAD score, right? So you no longer have to look at each individual inventory, but you can look at them together. And the green is still essential non-healthcare workers. And so we find something similar to what we found in the first model. So those essential non-healthcare workers that are Black have an elevated depression and anxiety, almost 0.8 standard deviations. And Hispanic essential non-healthcare workers also have a statistically significant elevated depression and anxiety. Depression for Hispanic is a little bit more than 1.1 standard deviations.
So I have a question. I can't remember, this controls for income as well?
Yes.
Okay.
Mm-hmm. Yes, it does control for income.
Okay, so, but I imagine you also see differential, health effects among different income classes, or?
We do, but it's not to the level of race.
Interesting.
So we did run this analysis, and that makes a good point, is I don't even know if we discussed this in the paper. We did run this analysis across income, but we didn't find as much difference, but there's also an issue with reported income, right? It's reported race is much more believable than reported income, but we do have other variables to get at income, right? Do you live paycheck to paycheck? And so we looked at those variables, but what felt the most convincing across the board and most consistent was the racial component. So our results are robust to limiting our data to working age under 65 across multiple measures of anxiety and depression, and including and excluding the states that had no stay-at-home order. So during our sample time, there was 5 states that did not have a stay-at-home order. So we excluded them. Results are robust. So across all inventories, essential non-healthcare Black and Hispanic workers have elevated levels of mental health distress. Being a frontline worker during COVID, it exposed them to an elevated level of mental health distress. And there's strong evidence that Black and Hispanic workers face different mental health stressors than white counterparts. It's especially important given Black and Hispanic workers are overrepresented in jobs, frontline industries, with relatively low wages and often no employer provided health insurance. So moving forward, qualitatively, our survey tells us these respondents do not report adequate coping mechanisms. So we ask questions about how do they cope with these stressors. Across the board, regardless of race, everyone, on average, our respondents report an increased use of alcohol and other substances. And we should begin to consider how might this lead to long-term generational effects, which are independent of actually contracting COVID-19, right? So the mental stressors of COVID-19 extend beyond contraction or mortality associated with COVID-19. When we start thinking of intervention and policies, interventions to help combat a looming mental health crisis might focus on meeting people where they are to help provide adequate mental health care. And this is really important when we think about the barriers to adequate treatment and cultural incompetence of what may hinder minorities from seeking mental health treatment. So the pandemic is exposing cracks in social structures, right? Whether it's structural, whether you want to call it structural racism, embedded racism, it's causing disparities in economic and social outcomes. So it is essential to ensure that pre-existing barriers in seeking mental health treatment do not further exacerbate the prevailing disparities in diagnoses and treatment of mental illness. We also have some other work that we're using. So we have a distance learning paper on parental mental health during COVID-19, which we find it is irrelevant of income and race, that there are some parents who are struggling mentally and there are some parents who aren't. And the only common denominator is whether their kids are struggling. And so we have some work on that. And we have another paper coming out that looks at, can we build trust and meet expectations during the coronavirus pandemic? And I also wrote a couple of newsletters and blog posts that build off of mental health and COVID-19 that I hyperlinked here if anyone was interested in looking at it. Thank you guys for having me. I look forward to comments, questions, and I'm really appreciative for this opportunity.
Great, thank you so much. So much to think about. I was wondering if anyone in our audience has any questions before I get going. No questions. Wow, so, one of the things, before we get to this, I was just thinking about the paper you mentioned on children. And as someone who has 4 children at home right now, remote learning, I would just make sure you include the variable for number of children.
We do.
Okay.
We do.
Because some people are doing okay. I don't want to talk about my state right now. So I have one right here. So have you, to get at the causal issues, of course, there she is very difficult. Have you thought about doing any qualitative work? I know it's really hard right now, right, given the current environment. And I know economists don't do it as much, but I imagine like doing some interviews would allow you to tease out some of the causal, mechanisms that you think might be at play. I mean, it's obvious that, they're pretty easy to identify based on the story that you've told, which, is quite plausible. But I'm just thinking about your reviewers, right? Who want, strong causal evidence of different things.
So that's a really good point. And for this survey, we did not. For this next education paper we're working on someone in education who is pushing more qualitative, which is great because Joaquim and Alberto are classically trained economists. They're in policy schools, but they're economists. And so we're all by nature more quantitative. I was part of a survey that Howard did that I got in late. Bill Spriggs was part of it. and it was mostly on the healthcare industry, and that was more qualitative, and it was really interesting to it more focused on whether people were getting unemployment benefits or not. And it really got at that a lot of people didn't even know how to apply for it or even know that they qualified for it. So I agree with you. I think the qualitative part could be really useful. And no, we have not made any steps to doing it yet. But I agree. I think that could be very useful.
And are you thinking of continuing this? I mean, because you have a panel, you could easily hop on again at some point.
So,
and it's expensive.
Yes.
Yeah.
So we have wave 3, which we didn't use for this survey. And that's because things started to get muddy about what was essential. And some states started to open up and then close that back. For our education, we use wave 3. There was some talk about putting wave 4 out, but the researchers that Gabriel Sanchez and Tyler Renee, they actually started another survey that's on something a little bit different that they're focused on right now. But we're hopeful that we will get another panel out fairly soon.
Interesting. You know, we were trying to do some some survey work early on when COVID hit. And one of the things that we were concerned about was targeting like the most vulnerable populations, especially when thinking about, you know, all of the variables that you've identified. And it was on a different topic, sort of on community response to the crisis and how neighbors are helping neighbors and that kind of social capital stuff. And what I didn't realize, I do a lot of survey work in developing countries. And I thought, okay, I'm going to do a survey in the United States. This will be really easy. And I didn't realize how hard it is to reach the most vulnerable in the US. And that a lot of survey firms use like mail-based surveys because a lot of families don't have access to the internet. You know, this, you know, COVID just laid out all of these crises so acutely, and I don't think they're getting any easier, right? There's been a lot of Band-Aids put on these issues, but it's going to be very, very hard. So I don't know if you know what kind of efforts you made to access those groups. I guess it's just really hard given. I mean, you're fortunate that you had this panel, and it could go right away. There's always trade-offs.
You know, I know that Sam Myers at University of Minnesota, I have a meeting with him soon. I had spoke to him over the summer, and I believe that he was part of a survey that was targeting minority communities and low-income households. I don't know how they were doing it, but I know that he was doing a survey in Minnesota that was targeting those specific groups, but I'm not sure how he was even doing it.
Okay, do we have any questions? Don't be shy. Maybe it's Friday.
It is Friday. It's been a long week.
It has been a long week. Maybe even just comments on the paper, even if you don't have questions.
You know, to build off of what you said about the community engagement, a current paper that we're working on right now, this one, How Schools Build Trust and Meet Expectations, that sort of builds off of that in the sense that we ask questions, educational questions in the survey about whether parents received calls from schools, whether they got a call from the teacher or a call from the principal, whether they got any emails. And it's really clear that those households that got more information and more regular communication from the school, they had higher expectations or they believed the school was doing a better job.
Oh,
right?
interesting.
Yeah, just from this, having these open lines of communication.
Was your sample large enough here to, was it representative at the state level?
No.
No. Okay. Yeah, that's really hard because it would be interesting if you could tell some state level story about, you know, how state responses affected this. Because I imagine that there's going to be some kind of variation, right? Just along the lines of what you've just suggested. It's like, is your state government reaching out to you? Is your state government, you know, sending you messages that reassure you? Or are there policies that they have in place that are making you feel better, right? It'd be really interesting to see.
So we control for state fixed effects in this work,
right.
in the paper I presented today. But yes, it's just, you know, we thought, oh, this nationally represented data set, maybe we'll get 5,000 observations. That's going to be great. And then you start to cut it across race, right? To create these stratas, and you realize well, it actually doesn't give us very many observations per state at all.
Exactly. It's hard. Shin, you have a question. Do you want to ask? Go ahead.
Yeah. My question is that because during COVID-19, everyone has a hard time. I think maybe the role of the community or your own personal networks play a very important role in dealing with all kinds of difficulties, including the mental distress. So I wonder, have you ever observed the role of community or social networks in providing some mutual assistance for across different racial groups?
We did not, and that's a very good point, right? Churches, community centers, that's a very good point. We did not look at that, and I am not familiar with any of the research on that in general as it relates to COVID. But I think that's a really important point and valid point that networks, whether it may be religious networks or just close knit communities, or right, these networks may have served as a way of mitigating some of the stressors of COVID.
Yeah, that was actually sort of along the lines of the research that we wanted to look at, not necessarily on mental health. Shin's one of our PhD students here at Pitt, is looking at how social networks affect the provision of public goods, right? So if you can't rely on the state for education, for all of these things, if you're sort of left there are these real gaps. Who do you turn to? How are communities responding to these issues? Because often, like in crisis response, you do see often resilient communities emerge in ways that are not really captured in like the formal nonprofit sector. So a lot of neighbors helping neighbors kind of thing. But that's a huge variable. Not everybody can rely on it. But I think there is some literature about how from my knowledge on I can't remember who it is, but we know this like social isolation leads to is highly correlated with mental health, or is a cause or a consequence of it. So I would imagine those community level variables to be very, very important, right, for some of those anxiety issues.
Yes, I agree, because for COVID-19, maybe the state, like there's a power vacuum, or you can say the state may not play a very positive role in the very beginning of dealing with COVID-19. And in the community level, I think like whether you should wear a mask, such kind of I think the community level is very important for in dealing with COVID-19. So maybe we should look at this in the future.
I think it's a really great point. I agree.
Do we have any other questions, comments, suggestions?
Hi, Jevay, my name is Linda Hooks. I'm a professor at Washington and Lee University and an economist, and not a labor economist. So with all of that as background, I saw that your results indicate that pretty much all measures of mental health, have this effect attached to them. Are there any implications for policy? Like if we were advising mental health experts where to start, were there any implications there, or was there just not enough data to really draw any?
I think for starters, so in the Brookings blog post that I did a panel for the Hamilton Project, and in that we discuss some of the other variables that we collected data on that we control for. And one was insurance. And one of the most disheartening things we saw is that these essential non-healthcare workers that were Black, I think Blacks were, I got to double check, I think it was like almost 10% of them did not have health insurance. So they're working through COVID, they're actively working, and they don't have health insurance. And the number was higher for Hispanic, not high, I think the number for Hispanic maybe about 6%, and those individuals that were white were about 2%. So I do think that there's policy, but I think just at the very basic level, making sure that everyone has access to health insurance is really important, right? And so we're thinking they're not getting employer provided health insurance, and they're making low wages. So the idea of them paying a few $100s a month for health insurance, maybe isn't even feasible given their lower levels of disposable income. And a lot of these individuals that didn't have health insurance were living paycheck to paycheck. I do think, just as universities have offered mental health services for everyone and have set up, a lot of universities have set up helplines because of COVID. I think these are things that are essential non-healthcare workers that are working, whether they be city workers driving buses, or there are grocery store workers. I think these are services that they probably need at a much higher rate and don't have access to. So even if it's just, and then so I do a lot of other research on substance use and mental health across disparities. And there's a whole body of literature on limits to or barriers to why minorities don't seek treatment for mental health and substance use disorder. And some of it is cultural, some of it is location based. Right, so there's these barriers that prior to COVID already existed. And then with COVID happening and exacerbating the need and demand for mental health services, I think there does need to be some dramatic policy shifts to make sure these needs are met. But I don't know that I personally have a policy suggestion.
Thank you.
You're welcome. I will say one thing, that ACA, who the Medicaid expansion has benefited has been the groups that are more likely to be essential non-healthcare workers, right? This 18 to 49, less likely to have children, right? This age group are also the age group that may have got Medicaid through Medicaid expansion, the more likely to lose their job, more changes in employment.
Great. Any other questions? So I'm just curious to see where you take this next. This is just really important work. And I think so many of us were wondering about this issue when the pandemic hit. And this, the pandemic has not gone away. It's still there. And people are still living this all the time. I see it, with my children's school, which my kids go to the Pittsburgh public schools, and they haven't gone back to the classroom. And you see the debates among teachers. They're not considered essential workers during this time. It'd be interesting to look at these different groups. But this is really important, and we're just so grateful that you've taken the time to spend with us today and to share this work. And we really look forward to getting it published. So just a big round of applause.
Thank you.
To you, Jevay. Really grateful for this.
Thank you. Can I leave one other caveat I forgot to mention?
Please. Yes.
One thing we should start thinking about looking in the future is this co-occurrence of mental health and substance use, right? The probability that you have an SUD, a substance use disorder, at some time in your lifetime, given you were ever diagnosed with a mental illness, is 50%, and vice versa, right? And
Yes.
So as we see more people with elevated mental health distress, it also starts to concern us when we think about substance use and making sure they get adequate treatment before they begin to medicate using substances that could turn into an even exacerbated problem, right?
Right. And I should just mention that, when we were thinking about doing this project, we sort of, the window ran out on what we were trying to do, but we actually were collaborating with the School of Pharmacy here at Pitt to look at addiction issues.
Mm-hmm.
And, how do people who are diagnosed, who are addicts, who are in treatment and no longer have access to treatment, how are they coping with all of this, right? And then not everyone has telemedicine either, right? So no, these are really important and crucial questions. So thank you very much.
Thank you for having me.
Yeah, and keep us posted on the paper. We can't wait to see it published.
Will do.
Okay, thank you. Have a great weekend.
You too. Bye.
Bye-bye.